Hello everyone, welcome back to Karan Academy. My name is Karan, and today we're going to be talking about hernias. So the most common hernia you're gonna come across this year are going to be your inguinal hernias, and I think you need to know them inside out in terms of the different types, what causes them, how do we treat them. But then we have a few extra hernias, complications. So we'll be talking about inguinal hernias, femoral hernias, a few other abdominal hernias, and then also talking about hiatus hernias with the esophagus. I've just put that in because it's, I think, information that's slightly relevant and can come up on exams. So the first few slides are going to be covering some basic anatomy. And I think this is particularly relevant while talking about femoral hernias of the anterior abdominal wall. So the important things you need to know are the three broad layers of the anterior abdominal wall, which is going to be you're going from deep to superficial, your transversus abdominis, internal oblique, external oblique, and then you have your rectus abdominis more anteriorly. And that's your linea alba passing in the middle. The layers of the anterior abdominal wall, which are quite important to know. I think you absolutely would have done this in your preclinical years with anatomy. So laterally, we have skin subcutaneous tissue, then two layers of fascia. The way I like to think about it, camper. So camping is high up in the mountains, which is why campers is more superficial. Then you have scarpas, external, internal transversus abdominis, which we mentioned. Below that is the transversalis fascia, and then you move into the peritoneum. Then you have extraperitoneal fat, parietal peritoneum, and the abdominal cavity. Medial, you have a few less things. So everything up to number 3 is the exact same. Now, instead of having external, internal transversus abdominis, you have the rectus abdominis muscle and the rectus sheath. Below that, you have the transversalis fascia, that is continuous medial and lateral. Then again, extraperitoneal fat, parietal peritoneum, and the abdominal cavity. And here's a graphical representation of that. So the rectus sheath, now what is the rectus sheath? The rectus sheath is an aponeurosis of 3 flat muscles covering the rectus abdominis, okay? The contents of them are the rectus abdominis muscles, the pyramidalis muscle that's anterior to the rectus, and then you also have your superior and your inferior epigastric vessels that pass through the rectus sheath. In terms of arcuate line, which is an important landmark, it passes halfway between the umbilicus and the pubic symphysis. It is important because of the arrangement of the layers of the rectus sheath. So above the arcuate line, the rectus sheath is both or runs both anteriorly and posteriorly, as you can see here. So this is the rectus abdominis. These are the 3 lateral wall muscles that we talked about earlier. These are their aponeuroses. So as you can see, they kind of split and encase the entire rectus sheath. And then you have below that, it's only anteriorly running and not posteriorly. The innervations are going to be the anterior rami of T7 to L1, and that runs between the transversalis abdominis and the internal oblique. Now, with your umbilical folds, you have 3 major umbilical folds. You have the median, medial, and lateral. So you have the median, which connects the apex of the bladder to the umbilicus in the fetus to circumvent and help with the genitourinary system development. Medial has the fetal umbilical artery, and lateral has the inferior epigastric vessel. So the lateral is the only one which has actual vascular supplies, versus the rest are converted into ligaments. And the inferior epigastric would obviously bleed quite significantly if it was cut, since it provides the vasculature for a large part of the anterior abdominal wall. And then the ligamentum teres, which you can see here, carries the obliterated umbilical vein. I won't go over this a whole bunch. I've just added this for completion's sake. But then again, I've briefly talked about the inferior and the superior neurovascular supply of the anterior abdominal wall. You can read through this in your own time if you'd like. And likewise with the nerves, they follow a dermatomal distribution. And yeah, so I guess the only thing I would like to talk about here is when we perform open abdominal surgery, the incisions we make are often in line with the pattern of the nerves. So this is when we retract the muscle laterally. And after making a paramedial incision, we do that so we preserve the nerves and don't actually damage them. Next, we have the inguinal canal. The inguinal canal is really, really important. And I think it's the hardest part about the inguinal canal is just visualizing it. So I think what I would highly recommend all of you to do is just to Google like a 3D video of the inguinal canal and just have a play around with that. Because I think once you visualize it, once you visualize the superficial and the deep rings, everything just makes a bit more sense. So in males, the inguinal canal mostly composed of the spermatic cord and the ilioinguinal nerve, sorry. And in females, it's the round ligament of the uterus. How does the canal actually develop? So for this case, let's just take the male specimen, for example, and we have the testes. We have the gubernaculum on one side and a structure whose name I'm forgetting on the other. And what happens is the testes pass through the different layers, right, into the the testes pass into the different layers, forming a scrotum. What I want to do by focusing on this slide is to show that the layers of the scrotum are quite continuous with that of the anterior abdominal wall. And you can actually visualize the different structures. And obviously, the structures are not going to be the exact same in the scrotum, but they are very similar and of the same origin. So this is kind of like what your layers are, and we've already talked about these. So skin, scarpa, external oblique, internal oblique, transversus, transversalis, and the peritoneum. And this is just a representation of what happens when the testes pass through those structures to pass into the scrotum. They carry along with them a lot of these structures. So things that it carries along with them. Obviously, you're going to have the outer skin. It also carries with it the what was that? So the scarpus fascia, that's now known as the dartos fascia. And then you can compare all of these structures with this. But what I'm again trying to just emphasize on is the fact that all the structures, or most of the structures of the anterior abdominal wall, are present in the scrotum under a different name and perform a slightly different function. Another thing I would like to talk about is the tunica vaginalis, which is composed of two layers, as you can see. In most cases, this closes up and is not really open, right? However, in some cases, you can have a situation where this passage is actually open, and that can predispose you to hernias or bowel herniating through this all the way here. The spermatic cord, so what are its contents? So the nerves include the genital branch of the genitofemoral. In terms of the arteries, you have the testicular and the cremasteric that are the main ones, as well as the deferential artery, which is the artery to the vas deferens. Other structures, not really relevant, but the only other one is the ilioinguinal nerve that passes next to the spermatic cord, but not really in it. Now let's talk about a really, really important structure called the Hesselbach's triangle. Not really a structure, but more so an anatomical space. The Hesselbach triangle is a triangle composed of three sides, as are most triangles. I don't know why I mentioned that. I thought that was pretty self-explanatory. The medial border is the linea semilunaris, which is going to be the lateral border of the rectus abdominis. The inferior border is going to be the inguinal ligament, and the superior lateral border is going to be the inferior epigastric vessel, artery and vein. Why is this triangle important? Now, when we talk about inguinal hernias, and we'll do so in a second, they can either be passing medial or lateral to this structure or this space, and that often distinguishes direct from indirect inguinal hernias. Another key thing to note is the presence of the deep inguinal ring, that is lateral to Hesselbach's triangle. So let's talk about the hernias. What is a hernia to begin with? So it's a protrusion of an organ or fascia through the wall of a cavity that doesn't normally contain it. The most common one that you're going to come up with is an inguinal hernia. It's most common. sorry, this should have said more, it's common in both sexes, but more so in males. That doesn't make any sense. Okay, moving on. The direct inguinal hernias are medial to the inferior epigastric vessel. Medial to the inferior epigastric vessel, which means that direct inguinal hernias pass through the Hesselbach's triangle. Indirect inguinal hernias do not pass medial, they pass lateral to the inferior epigastric vessel. So they pass outside of Hesselbach's triangle. Direct inguinal hernias are usually due to acquired defects in the anterior abdominal wall, versus indirect inguinal hernias are due to congenital defects with the patent processus vaginalis. Let's talk about that. So I'm going to go 2 slides back and talk about the, so this is the tunica. So the 2 layers are the tunica, and this passage is known as the processus vaginalis. A patent processus vaginalis just means that this is open, right? And as you can see, this is the deep inguinal ring. 2 slides ahead, this is the deep inguinal ring. If there was gut herniating into the patent processus vaginalis, into this green structure, it would have to pass through the deep inguinal ring, right? Because it's passing through the peritoneum into this space. Therefore, by default, a hernia that passes in the patent processus vaginalis would have to lie lateral to Hesselbach's triangle because of the presence of the deep inguinal ring, which is lateral, right? It is for this reason that indirect inguinal hernias pass laterally to the inferior epigastric vessel due to defects in the processus vaginalis. With direct inguinal hernias, now instead of passing through a pre-existing space, you have weaknesses in the anterior abdominal wall, so muscle. It then passes through the muscle and therefore herniates. So a key difference, sorry, I'm switching up between slides a bit. So key difference is that you can still have, sorry, there's another point I wanted to make before I talked about that. So the way the inguinal canal is formed, I'm a bit all over the place. Okay, so this is the deep inguinal ring. This is the superficial inguinal ring. What can happen is either you can have stuff going through this ring, and that's going to be lateral to the inferior epigastric artery, as you can see here, or you can have a defect in the actual anterior abdominal wall, and then it passes through this. An important point to make is that if it does pass through this, it can still go into the scrotum, but it would be separate to the spermatic cord. What I mean by this is, as you can see, you have this white structure here, right? This, what's this color? Wheat? Why did I say wheat? That's not even wheat. Anyway, sorry. It can enter the scrotal space, but it would not be inside this tubing, which is the spermatic cord, which is what I'm trying to get at. With direct inguinal hernias, they pass directly through the anterior abdominal wall, but would not enter the spermatic cord, but can still go down to the scrotum in this red space, versus indirect inguinal hernias, which are lateral to the inferior epigastric artery, which would pass through a patent processus vaginalis and into the scrotum through the spermatic cord, right? And that's basically what this table talks about. So direct and indirect, with respect to the inferior epigastric, direct are going to be medial, indirect lateral. Causes are mostly acquired weak muscular anterior wall, with indirect, which are mostly congenital. Buzzwords include weightlifting, because of that increased intrathoracic pressure and intra-abdominal pressure. With indirect, it's going to be more common in younger patients, since obviously this is a congenital defect, versus direct, which is more so a weakness, which sets in with age as well. The path of exit is the superficial ring, not the deep one. and it passes outside the covering of the spermatic cord and rarely enters the scrotum, but still can. Versus the indirect, which passes in the spermatic cord and therefore is more likely to enter the scrotum. Some other hernias include femoral hernias, which are more common in females. You can have a hiatal hernia, where the stomach herniates into the thorax, and we talk about this later. We have umbilical hernias, which are rather benign, and this is very common in babies, especially those with hypothyroidism, is an umbilical hernia. But when we talk about hernias, our two basic concerns are: is this reducible, which means can we push it back in? Is it strangulated? Now, a strangulated hernia is really bad. So what a strangulated hernia basically is when you can no longer reduce the hernia, you can no longer push it back, which means it's strangulated or incarcerated. That eventually is going to block up its blood supply and cause ischemia. Yep. And in terms of treating inguinal hernias, you don't need to know about the different approaches, but the main one is laparoscopic hernia repair. Most cases tend to be unilateral, but you can still have bilateral cases. What you do is you identify the spot. So if it is the deep inguinal ring because of the patent processus vaginalis or the defect in the anti-abdominal wall, you apply an artificial mesh on top of that area, which is sewn into the surrounding space, and that prevents the tissue from herniating again. And in the case, if it's an incarcerated hernia that is ischemic or necrotic, you might have to actually resect the necrotic part and anastomose the tissue, anastomose the bowel, basically. And that's quite hard to do and can lead to many complications. Next, we have hiatal hernias. Not really inguinal, of course, but covering the matrix thoroughly, I thought I'd put it in. So hiatal hernias is where part of the stomach herniates through the diaphragm. And there are two types you need to know. The first is a sliding hernia, and the second is a paraesophageal hernia. Now, a sliding, sorry, it's a bit late. So a sliding hiatal hernia is where the entire stomach, or the top part of it, slides through the same opening as there normally is. And this often leads to issues with the lower esophageal sphincter. Paraesophageal hernias instead is when you have another defect in the diaphragm and a part of the stomach herniates through that. It's more rare, definitely, and you have only a smaller part of it herniating through. And the lower esophageal sphincter tends to be intact. Now, of the two, you may often be asked which one increased the risk of GORD, and the answer is going to be a sliding hiatal hernia, because although you have protrusion of the stomach outside its normal space, the lower esophageal sphincter is still normal and still contracting. This is just a part of it's just come out, right? Versus here, where if you have a herniation of the cardia and the fundus, you're going to lose the patency of the lower esophageal sphincter, and that's going to lead to GORD. And both of them are treated surgically and usually have very good outcomes. You don't need to know anything about the surgical approaches to treating hiatal hernias. That is very niche knowledge. Yes, and that's all I had to say on that. Thank you all for coming. I hope that was helpful. As always, if you have any questions, feel free to shoot me an email or a Facebook message. And as always, please look after yourself and please look after your loved ones.